All right, for this lecture, we're going to talk about cardiovascular care of a pediatric client. So just some tips, right? Take it slow. I need you to recognize what the question is asking. I'm going to give you some ideas to help you remember if we're talking about these congenital heart defects, and kind of clump the information together as much as possible. I know that most of you want to know this, right? Unfortunately, this is not what NCLEX is. This is critical care. This is NICU. You're going to get this kind of information when you go through that kind of training. We need to make sure that we are focusing on just the basics. And the basics say most issues in congenital heart disease are related to a lack of perfusion. And since this is NCLEX RN and it's not the real world, we understand that those clients probably would be here, especially if they're having symptoms, but we're still going to focus on fixing the cause and making sure we work our way from least to most invasive. I think we'll see that again on the next slide. Make sure, when we're caring for these clients that we want to interact with parents first and the child second. Usually in the real world that kind of goes down simultaneously. We want to encourage the parents to be involved with the child, to ask questions, to hold the client if something is invasive is being done. We want to communicate with them at an age-appropriate level using simple language. We're going to try to keep our medical equipment out of sight. Again, that is easier said than done. And then make sure we're going, any kind of invasive procedure will be last. We're going to think about how the child is growing. Are there any restrictions, any delays in development? Are there any activity intolerances? Are they on the right pattern for growth and development? We want to ask about the mother's pregnancy, about specific comorbidities. So you think if it's just pregnancy related, it's gestational diabetes. But our folks can have diabetes type 1 or diabetes type 2. They can have any other medical problem. We want to think about medications that they would be potentially on for those comorbidities. So we're going to ask about both prescription and illicit drugs because those can have detrimental effects to the growth of an infant. Is there any familial history with cardiac issues? And of course, we've already said, making sure you're looking for those specific signs and symptoms. Poor growth, poor feeding, developmental delays, diaphoresis, activity or / exercise intolerance, cyanosis, syncope, palpitations, or edema. From my perspective, there are not a whole lot of questions about pediatrics on our unit exams. I don't foresee there being a whole lot of pediatric questions on NCLEX RN because most of this, especially the congenital heart defects, are pretty high level. Again, because most of them are going to require some sort of immediate intervention. These kiddos are probably going to be transferred to the NICU. But focus on their heart rate, their respiratory rate, and their blood pressure. So baseline congenital heart disease can be either born with or acquired. Usually if it's an acquired, we're probably more relating it to like an untreated upper respiratory infection, and now they had a rheumatic fever, and now we have rheumatic heart disease. I don't even teach that because I can't tell you the last time I've actually had a client with that in their history. So it's not something that I see a whole lot of. But what I do know is even if I'm worried about rheumatic fever, the outcome is an itis, and we're going to talk about itises later. It could be something some changes to the structure and function of the valves as well, because of how the bacteria is going to latch on to your valves. So we're just going to take it from a very straightforward, these are your congenital heart diseases, these are what we're going to do. This is where I see a lot of students spend the majority of their time trying to decipher, these types of congenital heart disease. So I want us to clump this information together. Usually, if I have an increased pulmonary blood flow, it's going to revolve around atrial septal defect, ventral septal defect, and patent ductus arteriosus. Notice that all of those have 3 initials. So we have an increased, those are our 3. Decreased pulmonary blood flow is going to be tetralogy of Fallot and tricuspid atresia. So these are going to be our T defects. And T, we know, is trouble, and we should know that decreased pulmonary blood flow can be a lot of trouble. Obstructive is pretty straightforward. I'm going to show you what coarctation of the aorta looks like, and you'll see that it makes a lot more sense when we talk about that in the same way that we talk about a stenosis. So this is going to be either an issue in the aorta itself with that pinching, or you're going to have a stenosis in your semilunar valve. So pulmonary stenosis and aortic stenosis. Notice it does not say, when we talk about obstruction, it doesn't say pulmonary blood flow. It just says obstruction to blood flow. And mixed is going to be transposition. So things are mixed up when you say the word transposition. It's transposition of the great arteries. Truncus arteriosus. So we have a change in our aorta, and then we have a change in our size and structure of the left ventricle. So hypoplastic left heart syndrome. So once you get these other ones pretty much down, then you're going to know the only things left over are your mixed blood flows. I will not ask you to identify whether or not ASD, VSD, or PDA is an increased, decreased, obstructive, or mixed congenital heart defect. That is knowledge. That is not an application and level question. It's good if you're just trying to remember those to do those types of practice questions, but my best advice to you would be to skip those questions. We've talked about our risk factors a little bit. Doesn't really change, what happened during pregnancies. Were there any, again, illicit medications? Was there any use of alcohol, diabetes? We walked through type 1, type 2, or gestational. Genetic factors are obviously always going to be a huge risk for us, especially when you have other syndromes involved. So syndromes like Down syndrome, or any other congenital abnormality or chromosomal abnormality. Again, I like to be repetitive because I want to reinforce these points. Make sure you are assessing your vital signs. So we've talked about the fact that tachycardia is the earliest sign and symptom that the child requires an increase in cardiac output. I say child, but that's anybody. So you have tachycardia, tachypnea, right? Continuous pulse oximetry. They're probably going to be on some sort of continuous monitoring because these clients are at risk for dysrhythmias. And then look for those red flag words, tachypnea or your other respiratory / perfusion words, tachycardia, diaphoresis, issues with suck, rest, suck, and failure to thrive. So failure to thrive is always a huge piece of those practice questions. Polycythemia, that could obviously going to make our blood very thick, very viscous. If I do have issues already with my pump and now I've taken away one of the ways that I can push blood around because I have too many red blood cells or whatever it may be, it's going to have an effect on your cardiac output. And then we'll talk about pulseless lower extremities for our congenital heart defects. I like to use just this memory tool. If I can remember 100 to 160, I'm going to kind of remember the ranges for an infant and for a child. So we'll look at that next. So with blood pressures, what we're looking for is somewhere between 60 to 80 systolic and a diastolic of 40 to 50. Our MAPS should be greater than or equal to the number of weeks of gestation. And we know, and it's not just infants and children, the compensatory mechanisms for low cardiac output is to have a higher heart rate. So infants and children are going to be somewhere between 110 and 160. We do go up a little bit when we talk about children. So we had infants and now we have children. Now we're just taking that number and going to normal. So it's growth and development. It's 60 to 120. If you can remember that, you can remember infants and children. And systolic is probably more important than anything else. But you do have a diastolic. Again, it's 40 to 80. Your assessment is the most important indicator for infants and children. You have to be evaluating them constantly. They turn blue very quickly. We have seen issues where we fail to do an assessment of an intervention. I was caring for a client with trisomy 17, I want to say. So literally we turned our back because the family came up and asked us a question, and we turned back around and the infant was blue, and this was a matter of 5 seconds. So again, we're going to put this big picture together, but really all we're talking about are signs and symptoms of heart failure. So when you have issues with impaired myocardial function, we've talked about activation of the sympathetic nervous system. You can do your perfusion words: fatigue, pallor, cool, clammy, weak pulses, absent pulses, hypotension. Those extra heart sounds, generally we said that it's going to be some sort of murmur associated with it. And of course, they are at risk for developing cardiomegaly, which is going to be a reason to be diagnosed with heart failure. Listen to lung sounds, count respiratory rates, monitor SpO2s, look for use of accessory muscles, difficulty breathing, activity intolerance, and then of course the more benign systematic venous congestion, which is hepatolomegaly, peripheral edema, ascites, JVD, periorbital edema, and weight gain. Weight gain will be probably most associated with wet diapers when it comes to assessing fluid volume for an infant. Notice though, what we're really talking about is I have my pump, so I have an impaired pump, and now I have signs and symptoms of left-sided heart failure and signs and symptoms of right-sided heart failure. That's all we're talking about. So, as we move along, I want you to really focus in on those key words, those signs and symptoms. And again, they're pretty straightforward. The only one that we add in here really for our infants and children are feeding difficulties, but the rest of them you see go hand in hand with the heart failure lecture or your heart failure material. All right, so that's the introduction. Now let's talk about the actual disease processes themselves. Atrial septal defect, ventricle septal defect, and patent ductus arteriosus. Okay. Think signs and symptoms of heart failure and a murmur. The only difference here that we're pointing out is if it's a PDA, it's not a routine murmur, it's machine-like murmur. And then with the PDA, we had widened pulse pressures, so we have changes in our blood pressure with bounding pulses. So PDA has 3 letters, but it also has 3 specific things: machine-like murmur, widened pulse pressures, and bounding pulses. Our treatments are pretty straightforward. For atrial septal defect, they're probably going to go to the cath lab and we'll take care of it down there. With PDA, we're going to include the use of indomethacin. So we're going to hope that that closes that patent ductus arteriosus. And again, this can be done during cardiac catheterization or may require surgical management. VSD, we're hopeful that that just closes on its own in that first year. However, if you are symptomatic, we can certainly do other procedures. When we are looking at this from just an A&P kind of standpoint, what I want us to think about is we know that 2 of these 3 are going to involve the septum. So you have your atrial septal defect. So this tissue separating right from left is the septum. And you're going to have openings there either in the atria or in the ventricle. All right. With the patent ductus arteriosus, instead of it being a pinching, it's an opening between your aorta and your pulmonary vasculature. So we have a decrease in cardiac output because of the mixed blood flow. It's not a mixed disease, just because of the way that the duct is open. The majority of these types of questions make really good hotspots. You know, kind of we talked about the hotspots when we're listening to heart sounds. You know, if we're thinking about best locations to palpate pulses, or when we're talking about congenital heart disease, are you able to recognize where ASD, VSD, and PDA are located? All right, for our, oh, went too fast, sorry. For our decreased pulmonary blood flows, remember we said our T's are our trouble, and again, I'm going to give you that information later on. So we're thinking tetralogy of Fallot and tricuspid atresia. Remember, since these are our T's and they are trouble, it means decreased blood flow. We'll throw in the pulmonary. What we're going to look at, our tetralogy of Fallot is simply a boot-shaped heart. So if you do an X-ray, you may see something like this. It's a tet, so it's 4, and it's 4 congenital abnormalities altogether, which makes it the tetralogy of Fallot. We're going to talk about tet spells with tetralogy of Fallot, and we'll talk about pulses and squatting and all that good stuff. Tricuspid, so it's telling you where, and then you have without growth, atresia. It's the failure of that valve to form. Let me show you pictures later. Okay, so tetralogy of Fallot and tricuspid atresia, we see the same information. Think signs and symptoms with heart failure and a murmur. So the 4 defects are going to include VSD, ventral septal defect, pulmonary stenosis, so we know we have some sort of impediment, some sort of obstruction, an overriding an aorta, and a right ventricular hypertrophy, which is just the opposite of left ventricular hypertrophy. These episodes are going to cause our infants to have cyanosis and hypoxia. You can see them annotated as either hypercyanotic spells or blue spells, that's very old school, or TET spells, but I still hear them called TET spells every once in a while. And this occurs when that oxygen demand is exceeded by what the body is actually using. And this can happen with crying, feeding, or defecating. So think about things that the client is doing to cause excess stress on the heart. With increasing cyanosis, squatting, clubbing of the fingers, and poor growth may occur. Clubbing, it's going to take a long time. Hopefully what we're thinking of is getting this client out to surgery in that first year. So hopefully there won't be any issues with clubbing. But you will definitely probably see developmental delays or growth delays. Squatting for our older clients is actually a compensatory mechanism, and it's very effective. On our infants, we're going to squat them. So we're going to talk about the knees to the chest when they are having issues with one of these TET spells. So tetralogy of Fallot is going to require surgery. We need a complete repair. What we're going to look at is changing the structure of this pulmonic valve. Remember, that's a stenosis. So you're thinking cath lab, balloon valvuloplasty. We have a ventral septal defect. Now we could let that close on its own. However, since we're already there for the surgery, we can be thinking about closing it off. The overriding aorta and the thickened muscle of the myocardium itself. So the cardiomyopathy, this growth, right ventricular hypertrophy, is going to go along with our overriding aorta, and that simply means that basically your aorta is in the wrong place. So things that we would expect to see potentially would be cyanosis. These clients are going to get hypoxic fairly quickly. We're talking about 65 to 85. Again, we talked about clubbing. Because of the underlying disease process, polycythemia, which is going to increase their blood clot risk. We're going to monitor them for hemoglobin levels that are over 22. Again, our body's compensatory mechanism to a lack of oxygen is to create more red blood cells. But this can be problematic by making that blood thick and viscous. We said the complete repair is usually performed in the first year of life, and it involves sternotomy and cardiopulmonary bypass. This is kind of what I always think about, these higher level analysis level questions when you're thinking about tetralogy of Fallot. It's this therapeutic phlebotomy. It's this increased risk for blood clots because of the polycythemia. We get questions from the parents. They want to know what's the outcome for their infant born with tetralogy of Fallot. And that would be us making sure that they understand that this will require surgery at some point in hopefully that first year. And it's going to be pretty invasive. Putting an infant on bypass is a pretty big deal. The infants themselves may display nasal flaring, the use of accessory muscles or abdominal breathing. It's hard to see accessory muscles on an infant. Issues with a non-productive cough. We're going to look for those excessive crying, because that's going to be that activity intolerance. So make sure you're listening, looking, feeling. And then it talks about high-pitched screaming, crying would be because of this increased in intracranial pressure. But that's a neural answer, and this is a cardiac test. So you probably won't see that from me. So what do? We are going to place the infant in the knee to chest position. That's that squatting position. We're going to administer 100% oxygen because their baseline at that point is 65 to 85, and it could be worse. Morphine will help because it will decrease their crying. It will improve their respirations. It also decreases preload and afterload just a little bit to help decrease the cardiac workload of the heart. We can administer fluids continuously if we think that this client has an issue with polycythemia. And of course, you want to make sure that you are documenting anything that we do and documenting your evaluations, so the infant's response. When I think about like tetralogy of Fallot as far as a hot spot, it's basically kind of like this triangle. There it goes. I have issues here, here, and here. And that's kind of my upside down triangle. And then of course you know that the overriding aorta is just off of the aorta. So we've talked about squatting and why that's important. Health promotion. Don't interrupt them. Cluster your care. Provide a calm, quiet environment. Making sure, if you have a lot of equipment that's going to make a lot of noise, that it's not going to startle the infant. We can offer a pacifier during crying to help calm them. Provide small, frequent feedings. Again, if you can't breathe, you can't eat. And then we're going to have our clients or our family members swaddle or hold the infant during procedures, just to make them as comfortable as possible and include them as part of the process. So that is Tetralogy of Fallot. You'll notice it has the most PowerPoints because it's a pretty big topic. It doesn't happen a whole lot, knock on wood. But when it does, you have multiple problems to fix. So our other decreased pulmonary blood flow is tricuspid atresia, failure of that tricuspid valve to develop, right? Here, what we know is that generally speaking, we're going to have to perform surgery. We said the same thing about Tetralogy of Fallot. Right, this is going to be performed in 3 stages, and for me, that is good enough. I'm not going to ask you anything about a Fontaine or a bidirectional Glenn or a Blaylock. I'm going to ask you, you're caring for a client with tricuspid atresia. What does the nurse need to do? And we need to do all those things that we talked about for heart failure. Keeping them elevated, giving them supplemental oxygen, listening to their lung sounds, assessing for edema. So that's really it for tricuspid atresia. Obstruction. So our coarctation. So I have a pinching of the aorta. I have a narrowing of the pulmonary valve and a narrowing of the aortic valve. Those narrowings are called stenosis. And what we're talking about for obstructive is no cap. I don't want coarctation of the aorta. I don't want aortic stenosis, and I don't want pulmonic stenosis. So, it does not change for us. Signs and symptoms of heart failure and a murmur. Again, let's look at the difference. Coarctation of the aorta will present as an increase in blood pressure in the arms, bounding peripheral pulses, in the upper extremities and decreased pulses bilaterally, distally, so the lower extremity pulses. So it's COA again. I have 3 letters and I have 3 assessments. Increase, increase, decrease. Blood pressure, pulses, pulses. So again, we've talked about this obstructive blood flow, the fact that it's a typical NCLEX style question. Can you identify or differentiate coarctation of the aorta from tetralogy of Fallot? So with coarctation, what I wanted to point out was that you have this narrowing, right? Much better picture. You have the narrowing of the aorta. So you know you're going to have a decrease in cardiac output, and you're going to have an issue with blood backing up to where it came from. In this particular case, it would back up to the left ventricle, left atrium, and to the lungs. All right? This is what it should look like here. So you can see that that's a significant difference. We're going to manage this. Again, remember we said surgery. We can do this via the cath lab with a balloon angioplasty. Unfortunately, we do know that restenosis can occur. So at that particular point, we may have to consider surgical management. And we're going to have that client on mechanical ventilation, usually some inotropic medications to improve cardiac output, very low dose. And then we're going to perform a resection and re-anastomatize that to the rest of the unaffected aorta. With pulmonary stenosis, that's again, you're probably going to do this in the cath lab. We can do it through a balloon, a valvuloplasty, or a valveotomy. So basically, we blow up a balloon to make that opening better, or we go in and we do cosmetic surgery on your pulmonic valve. Aortic stenosis, we're going to talk about a lot when we get to valvular. Aortic stenosis is a big deal. It's impeding blood flow to systemic circulation. That's going to obviously increase your risk for heart failure. So, all of the signs and symptoms are pretty much the same. So you have decreased cardiac output, decreased oxygen, you have activity intolerances. Here we see low blood pressure with tachycardia. Now, if you remember from our shock lecture, we said that that's a compensatory mechanism, but that's not going to be sustainable. This is why we have to do immediate care. Here they can end up with a hypertrophy because of that stenosis, right? So that left side of the heart has to work harder to overcome the resistance, and that means blood is going to back up. Usually it's going to back up into your pulmonic circulation and then into your lungs. And then we're going to manage it either with angioplasty or plastic surgery, the valvotomy. For us, we just want to observe for signs and symptoms of heart failure, poor feeding, fatigue, cyanosis, tachypnea, and edema. Listen for heart murmurs, abnormal heart sounds. Because we want to improve cardiac output, we can certainly consider diuretics because we expect there to be fluid accumulation. We've talked about the use of inotropes to maintain cardiac output. And then you can do prostaglandins in neonates to keep that ductus arteriosus open if needed. So in this particular case, you notice this is really kind of the only thing different that we've talked about is using this medicine to keep the PDA open. I'm going to try to keep this simple. Basically, because I have an obstructive blood flow and some of that blood is not getting oxygenated as needed, and usually because this is involving both the left side and the right side for the disease processes, so those semilunar valves, we want an alternative route for that blood to be able to pick up oxygen. And if we don't have that PDA open, then we're not going to be able to perfuse as effectively. So mixed blood flow. So we're going to talk about some T's again, and I'm going to give you guys again that breakdown. So we're going to look at transposition of the great arteries, trunctus arteriosus. We've talked about hypoplastic left heart syndrome. And again, I see T's, so I see trouble. So usually we know that this is going to involve some sort of surgeries. So trunctus arteriosus is failure of the pulmonary artery and the aorta to develop correctly. So you end up with one big vessel and it overrides both. So they're going to need corrective surgical repair. We want blood going to the right places. Hypoplastic left heart syndrome is just an underdevelopment of the left side of the heart. So you can imagine how that would affect cardiac output. The defect is fatal in the first few months of life without intervention, and usually that intervention is going to be surgical management. We can certainly have them on a ventilator, and we can be giving them prostaglandin to maintain that patent ductus arteriosus. But we just want to make sure that we have the ability to maintain adequate oxygenation and adequate perfusion. And again, you see this 3 surgeries. I don't expect you to know it's the Norwood, it's the Glenn, the Spontaine. It's hypoplastic, so there's our T, plastique, left heart syndrome. It requires surgery, and it's a process of 3 surgeries. So transposition of the great arteries, trunctus arteriosus, and hypoplastic left heart syndrome. Again, we think signs and symptoms of heart failure. So here we have a normal heart, and here we have a persistent trunctus arteriosus and a ventricular septal defect. So you see we have kind of a change in how blood flow happens. So on the left, we have very specific left and right-sided blood flow. All right, and even though that aorta is behind the pulmonary vasculature there, that's how blood should be leaving our body. With truncus arteriosus, this becomes this. So it's this one great big vessel, and you have all of this blood flow here. So it would be impossible for these clients to maintain cardiac output on their own. We need to do immediate interventions. So here's kind of what hypoplastic left heart syndrome is going to look like. We don't know why. Again, we've talked about genetics. We've talked about the effects of medications or other comorbidities. What I mostly want to focus on is you see the opening in the left ventricle here. That's all the room that they have to actually pump out cardiac output. You see the development of all this extra myocardium. So, unfortunately, that muscle is going to be thick. It's going to be resistant to actually pumping. You can have issues with your valves. So on the left side of the heart, the aortic valve and the mitral valve can be too small or absent. And again, you can see why this might require surgery. And it's a T word. You know it needs surgery. So all of these typically make good hotspot questions. So when I go through and I'm looking at our differing places, if I see a patent-form ovale, I don't really talk about that one, but it's basically in that same space as our atrial septal defect. We do see here now I have this patent ductus arteriosus. So I have an opening between our pulmonary vasculature and our aorta. Here I have coarctation of the aorta. And then again with our tetralogy of Fallot, we talked about kind of how it's making this V or triangle shaped pattern, and it's inclusive of our 4 different disease processes. For any congenital heart disease, our goal is that the client will be symptom-free, that they'll be able to participate in ADLs, they'll have normal growth and development, no issues with feeding. So very similar to what we would do for our clients with heart failure. Monitor vital signs, including the respiratory status, look for nasal flaring, look for accessory muscles, listen to lung sounds for crackles, monitor for those hypercyanotic TET spells. Make sure we're looking for signs and symptoms of heart failure. It's left-sided, it's right-sided. Make sure that they are getting adequate nutrition. This may be something that we have to do for them. We've talked about clustering care, so planning your interventions to allow them to rest. And then generally speaking, a lot of these issues will be seen down in the cath lab. So, I've been talking a lot about trouble or no trouble, or our T's versus our other congenital heart defects. So what we've done here is that we've tried to put our T's together. So I have tetralogy of Fallot, truncus arteriosus, transposition, tricuspid, and then I know it's a stretch, but it's left ventricular hypertrophy, so my 2 T's. All of these will need surgery now. And that's such a great health promotion and maintenance question, right? We know that to be compatible for the long term, we're going to need surgery. No trouble, your ASDs, VSDs, PDAs, and down here is the only time I really talk about the patent-form ovale. Remember I said it's similar or it's in the same area as our ASD. So these can usually either be handled in the cath lab. We can give prostaglandin, indomethacin, so PDA, remember proper drug administration. And then the patent-form ovale will usually be like our VSD, and it will try to close on its own. Again, we kind of see the different defects, and here we see our PDA, we see VSD, and we see tetralogy of Fallot. Remember our basics. Treating signs and symptoms. All of these congenital heart defects are acute changes in condition, especially if they're symptomatic. So we need to restore oxygenation. We need to preserve the myocardium. We're going to focus on the things that I can evaluate, that I can assess. So strict I's and O's. What goes in must come out. Daily weights. Again, daily weights will be a dry weight. Usually, again, it's the same. It should be performed at the same time each day. Observe our vital signs. Make sure that we're looking at our medication. So Digoxin itself is something that I still do see in pediatrics. It'd be interesting to see my folks who work in the pediatric setting how much you are actually giving it now. But you do have parameters for digoxin, just like you would for an adult. ACE inhibitors. Remember we talked about preventing ventricular remodeling, and since most of these are going to lead to some sort of heart failure, that's why we would add the ACE. Obviously, it has the added benefit of decreasing blood pressure. Diuretics, continuous telemetry, monitor for nausea and vomiting, provide frequent periods of rest, cluster your care, elevate to the head of the bed, give O2, small frequent meals, good skin care, and encourage the parents or guardian to stay with the child. That is it. That is 46 minutes of pediatric care. I want to try to keep it as simple and straightforward as possible. Focus on the information that is different to help you be able to put that information into context for what they're asking. And we'll get some practice questions here as well in class. So if you have any questions, please feel free to reach out. Let me know.